Good afternoon, everyone. My name is Natasha. We'll get started in just a few minutes to allow more folks to join. As we wait for other participants to join, if you can go ahead and drop your name in the chat and perhaps where you're working at right now or what your role is, and just welcome everyone. Thank you, Janice. Sarah P., welcome. Thank you for joining us. Michelle from Sarasota Memorial, thank you. Happy to have you. And we'll wait one more minute and we'll get started. We got someone from the Puerto Rico chapter. Welcome, Sandra. Okay, so it's 12 o'clock and we want to be conscious of everyone's time. So we'll go ahead and get started. If you like, please switch to speaker view so that you only see me on the screen. Or you could have gallery, whichever way you prefer. So again, thank you and good afternoon, everyone. Thank you for joining us today for the CRCR certification series course in the first of this year. My name is Natasha Caballero and I am a member with the Florida HFMA Certification Committee. I work for Sylvester Comprehensive Cancer Center with the University of Miami as a director of patient access. I have about 17 years, so a little bit over 17 years of experience. I've had oversight over outpatient clinics, admitting, scheduling center, the benefit advisors, financial counseling, insurance verification, and most recently our COVID-19 testing, vaccine, and infusion clinics. I also have an MBA from Florida International University, as well as Lean Six Sigma Green Belt certifications. And I hold HFMA's CRCR and CHFP certifications. Just a quick reminder before starting with the content. We ask that along with these sessions that you go following along with the online course. And so as we finish one unit or go through the unit, sort of follow through the online content so that you can be up to date and current with the information being taught. Also, the session is being recorded and will be available on the Florida HFMA YouTube channel. You may also find previous sessions there. So if you'd like to sort of go into future content, you could do that for previous sessions that were recorded. We ask that you put your questions in the chat and we'll go ahead and take them at the end if there's any questions. We ask that you stay on mute and off camera, but feel free to come off mute and join at the end to answer any questions there may be. And lastly, the materials should be posted on the Florida HFMA website. And so with that, we're going to go ahead and get started. The first unit is about patient-centric revenue cycle. And so today, we're going to be going over units 1.1 through 1.5. In this course, sorry, give me one moment. Okay, this seems to have gone to the next section, so I apologize for that. I'm going to stop sharing my screen for one moment and get the right presentation. My apologies. I think we're ready. All right, my apologies once again. So starting with Unit 1.1, this course will provide you with an overview of a patient-centric revenue cycle model. I will share with you that when I started my career, and I was actually in PFS, it was not an easy job. The processes were not necessarily customer service or patient-centric per se. This was maybe 17 years ago. So things I'm sure have changed since then. And so in this unit, we will identify the three critical segments in the revenue cycle, identify the activities that occur in each segment of the revenue cycle. And so when I meet new folks and they ask what I do, I explain that, we are the first face patients see when they come into the building. And so it's very important to understand what happens before patients come in. And it's obviously very important what happens when patients are here and what happens after that. And so in this wheel, it sort of goes over what happens pre-service, which is scheduling, and pre-access processing, and these set the stage for effective patient communication and data collection. During the pre-service segment, we will be completing information and moving from point to point. As you can see here on the wheel, it starts with scheduling, it goes then to pre-registration, insurance verification, etc., and so forth. It is critical that providers optimize these steps to avoid downstream impact, such as denials, increased cost to collect, and increased bad debt and dissatisfied customers. Engaging the customer. So surprising patients with healthcare bills, like we did years ago, it's not acceptable anymore. And in fact, there's a lot of laws that are now in place to make sure that doesn't happen. In addition, we do a disservice to our patients when we treat them clinically, but then don't really address their financial needs and surprise them with bills. The healthcare consumer landscape is changing. Consumers want to be known and understood in order to get a personalized health experience. Therefore, understanding customer attitudes and preferences across the healthcare journey is key for not only improving the experience, but also for supporting healthy behaviors, achieving better outcomes, and remaining competitive. Like we said before, this pre-service stage includes scheduling and pre-access processing that set the stage for that communication with the patient. During this segment, the encounter record is generated and the patient and guarantor information is obtained and or updated as required by some of our policies. For example, we screen for medical necessity. We look at health plan coverage and benefits. This is when they usually get verified, pre-authorizations are obtained, estimates are created to inform the patient and let them know what their deductible, coinsurance, and or copay amounts will be. This should be done again prior to service to help the patient make informed decisions, not to be surprised by bills and then later on have to figure out a way of getting assistance for those bills. In addition, we want to make sure that particularly with surgical events, that patients get informed of things that they may need to do. For example, not bringing their personal items, their wallet. So a lot of this communication and these phone calls per se and interactions are happening or should be happening before the fact, the service. So engaging the patient at the time of service, and it all begins with the patient arrival. And I would say from personal experience, it's important to set the tone at the moment the patient steps foot through the door. And so it's that interaction with the patient, understanding that they don't want to be there. You want to make sure that you smile, that you provide them with the right friendly but professional body language. And so that you reassure them that you're there to help. You may not have all the answers, but you want to make sure that we don't add to that already existing anxiety. Ideally, when the patient shows up, they have been pre-registered unless obviously it's an ED. And the patient can go directly to that service unit versus waiting in a main registration area. Hopefully by the time they show up, consents are signed. And there's a lot of ways to do this by doing e-check-ins, for example, and having the patient have an EMR portal account and taking care of all these things before they arrive for their appointment. This may also include making payments ahead of time, adding and updating demographic information, etc. So the interaction with the patient at the time of service hopefully is a minimal. We also want to, for the time of service, we want to make sure, and one of the most important aspects besides that interaction with the patient is doing a positive patient identification. And this is for safety and security. We want to make sure that we're asking for their government ID, their insurance card, making sure that we're verifying their name, date of birth, all of these things. And in most cases, patients are given an armband as part of hospital policies. Unscheduled patients or non-pre-registered would have to go through a comprehensive registration process, and this usually is very time-consuming. Post-service. And so post-service includes the account activities that occur after the patient is discharged until the account reaches a zero balance, such as final coding for all services and providers, preparation and submission of claims, payment processing and balance billing and resolution. This process is so independent on the actions that occurred pre-service and time of service, and providers should invest in optimizing processes and embracing technology that avoids rework and increases cost to collect on the back end. So on the back end, patients want healthcare conversations and communications that are personable to them. No longer can we treat patients the same, both in collection conversations and modalities of communications. Patients want more digital and multimodal channels of communication. So some key points from this section: 3 segments of the revenue cycle. We have pre-service, time of service, and post-service. Pre-service is where scheduling and pre-access processing is completed. In time of services, a final account is reviewed, completed, patients being identified, armbands printed, etc. Maybe one last collection or missing consents or other forms. This is when that's happening. And then after the fact, account activities occur after checkout or discharge is completed, such as coding, balance billing, claims, etc. And so this goes into more in-depth as to what happens during that post-service stage. And we reviewed a few already, but let's go into this in more in-depth. Post-service, again, is the third and final major segment of the revenue cycle, and it includes account activities that occur after the patient is discharged until the account reaches a zero balance. And so you'll see here in the bullet points that you have orders entered, results reported, charges generated, final coding is happening, preparation of claims, payment processing, etc. And this brings us to unit 1.2. We're going to talk a little bit about healthcare dollars and cents. And so now more than ever, people are asking about the price of healthcare. They are called on to make more decisions and pay for more out-of-pocket costs for the services they receive. They're looking for the information they need to find and pay for quality care. And so especially those patients that have the buying power, if you may, so the cash to pay for services or the healthcare card, healthcare insurance, they can decide where they want to go. And so they're not looking just for, pricing information and whatnot, but they're also looking for quality care. Healthcare dollars and cents aims to answer these questions to help make sense of the price and value in healthcare. Patient financial communications. So these voluntary practices address the area where best practices are most urgently needed, focusing on financial discussions that take place in advance of healthcare service, at the time of service, in the ED, and in other care services. They provide definite guidance about when and where patient financial discussions should take place and who should participate and what the topics should be. First and foremost, it should respect patient's privacy. Of course, in the ED, no discussions should occur before a patient is screened and stabilized as per the EMTALA law. The provider-patient conversation should consist of the following: compassion, communication, written follow-up, compliance framework, and the HFMA's adopter program. This is certainly the hot topic providers are dealing with right now due to the CMS mandates to provide all charges in a machine readable format and 300 shoppable services as well. And that's price transparency. The need for transparent healthcare pricing has never been more important due to the need to help customers make smart, educated decisions about the care they receive. In order to provide a patient with information that is meaningful to them, several factors must be included. For example, the type of hospital service based on CPT or MSDRG codes, total charges, contracts or fee schedules per health plan, real-time patient eligibility of patients' current out-of-pocket, and recognizing the industry's need for guidance concerning this topic, HFMA convened a task force to develop two documents: a price transparency report and a consumer guide to healthcare prices. Both documents can be found in the resource section of this course. HFMA created a medical debt task force that built off an HFMA's patient-friendly billing work. Best practices include educating, communication that must be clear, concise, correct, and patient-friendly, establishing policies that make sure they are followed internally, being consistent, coordinating to avoid duplicate contacts, exercising good judgment, having timing start the clock when the first statement is sent, and report and track both to credit bureaus if needed, and tracking all consumer complaints. Some key points for this section: healthcare dollars and cents is the name given to 3 HFMA revenue cycle initiatives: patient financial communications, price transparency, and medical account resolution. Also, communication and sharing information with patients support higher levels of patient satisfaction. And so that brings us to our next or first polling question: which items are not in best practice? And so we'll give you some time to read the question and the answers and pick the best one. So which items are not in best practice? And we have one answer so far, 3, 4. We'll just give you guys a few moments. Okay, so we're gonna go ahead and end the poll and review the answer. And so most of you said the correct answer, which is not a best practice item, is to report to healthcare plans when patient accounts is transferred to collection agency. And that is the correct answer, so great job. Next polling question. Which option is not a main HFMA health dollars and cents revenue cycle initiative? And some of you are still answering. And I think that's it. We'll go ahead and call it. And yes, the right answer is process compliance. So you guys were definitely paying attention. Great job. All right, so this brings us to unit 1.3. Patient experience and satisfaction. At the end of this course, you should be able to speak about these 3 bullet points. Patients expect value for their healthcare dollars, including greater transparency of quality and price information. Patient satisfaction also means that patients understand the provider's payment expectations and terms. And the 3 bullet points sort of go over identifying patients' expectations related to revenue cycle, the HCAP survey, and the impact of communication and customer service to patient experience and satisfaction, to recognize the strategies used by the revenue cycle leadership and staff involving or in improving overall patient experiences, and to identify the hard and soft costs to the provider of poor quality patient experiences. The HCAPS is the Hospital Consumer Assessment of Healthcare Providers and Systems Initiative. The objective of this initiative is to provide a standardized method for evaluating patients' perspective of healthcare, hospital care. For additional information, visit cms.gov and search for quality initiatives. Of the 27, only 1 question encompasses the entire patient experience, which is, would you recommend this hospital to your family and friends? It is important to go the extra mile by creating patient-friendly processes aimed at improving the overall patient experience. Implement processes that are patient-centric and efficient. Educate patients about insurance coverage and out-of-pocket that can alleviate concerns. And communicate financial information clearly, consistently, and timely. Ultimately, treat the patients as you wish to be treated. Cost of poor quality patient experiences. And so this goes over 3 bullet points. So hard cost is the loss of future revenue. Great clinical care can be eroded based on both the experience in the front end and back end collection efforts. So that means that it doesn't matter how good the doctor is, the providers are, if you don't have a solid front end or back end collection efforts, that can deeply influence how the patient feels about your organization or your hospital and potentially go somewhere else. And so that would be a hard loss of revenue. Soft is a negative experience passed on various ways and to various audiences. And lastly, quality also has an impact in billing, physician, and case management. Staff should receive intensive training in the art of welcoming behavior. They have a responsibility to efficiently and professionally gather all information necessary to support the patient's intake process. It is important to recognize that there is a significant organization cost if policies pertaining to communication, customer service, and quality assurance processes are not established, and legal issues can also arise. For example, if a patient is registered with the wrong MPI and the correct patient arrives in the ED and is allergic to penicillin and it is given to them, then that can have serious legal issues. And so we have now another polling question. What is the objective of the HCAHPS initiative? We just learned this. So we'll give you just a few moments to answer this question. And we'll go ahead and end the poll and share the results. And so most of you answered to provide a standardized method for evaluating patients' perspective on hospital care, and that's the right answer. Unit 1.4, collaboration and continuum of care. And so in this section, we will discuss departments and personnel whom revenue cycle staff and leaders will work with in a patient-centric revenue cycle. Collaboration with information technology. Healthcare providers today are faced with an increasingly complex operating environment. Using and optimizing technology provides a competitive edge and decrease costs by streamlining operations, increasing productivity, accessing profitability by health plan and patient type, and providing quality care. Organizations that do not keep up with information technology may be faced with limitations on their ability to attract and retain not just patients, but staff as well. And some key points in this section. Information technology enables healthcare providers to enhance patients' experiences through efficient scheduling, tracking, and reporting. Common software's applications include, but are not limited to, scheduling, admit, discharge, and transfer system, ADT, pre-billing editing, electronic claim generation, payment tracking, exception-based work use, AR management, cash posting, denials, refunds, and collection transfers. Some EMRs will state that they do not require bolt-ons on pretty much on a correct statement. Additional bolt-ons are electronic eligibility verification, estimation calculator, automated prior authorization, computer assisted coding, chart integrity, claim scrubbers, automated claim statusing, denials and appeals support, and analytics. As patients become more comfortable with the internet, they are demanding online access. They expect providers to offer online scheduling, bill pay, and customer chat, just to name a few. Collaboration with clinical service is also very important. And clinical services prepare for and serve the patient as well as confirm the accuracy of the patient's information in a timely manner. So some examples of this could be that although focused on the clinical needs of a patient, as they should be, a number of activities support revenue cycle, as well as reviewing patient chart and armband to ensure accuracy, obtaining consent, especially during surgeries or procedures, entering charges accurately and timely, and documenting care. Finance provides analysis and reporting to ensure compliance. And so this involves a collaboration with finance. They're usually responsible for compliance with state and federal reimbursement reporting requirements, but they also provide modeling for contract negotiations and estimates the impact of regulatory changes on the provider's financial performance. Next polling question. Which is not a department that supports and collaborates with revenue cycle? So choose your best answer. Is it clinical services, finance, assisted living, or information technology? And we'll go ahead and end the poll. Share the results, and most of you were correct. Assisted living is not a department that supports and collaborates with I would say for the most part. There may be some exceptions, but the ones that collaborate on a daily basis with revenue cycle are clinical services, finance, and information technology. Continuum of care. Continuum of care is a way of coordinating and linking healthcare resources, facilitating a seamless movement along all the care settings. It seeks to implement linkages to connect patients who are leaving to acute care setting with post-acute facilities and services. The coordination of care has gained importance as alternative payment models expand to include bundle payments. Physician offices provide the order, schedule the service, and usually obtain authorizations. And some key points for this section, it was just one slide, but continuum of care is a way of coordinating and linking the healthcare resources to avoid duplication, thus facilitating a seamless movement along all care settings. And it involves healthcare professionals in multiple settings and on multiple levels. And another poll question. Which option is not a continuum of care provider? Okay, we'll go ahead and close the poll. and share the results. And yes, that would be option 2, health plan contracting. Great job. We're up on our last section today, and this is compliance and HIPAA regulations. And so in this section, we'll talk about the rise in corporate compliance programs, including the complexity and importance components of the programs, the role of compliance officer, HIPAA, including electronic transaction codes and privacy and security components. One second. There we go. And they cover the risk key areas that are perceived to lead to potential fraud and abuse. And such risk areas include upcoding of MS-DRG assignments, inaccurate or incorrect coding, bundling and unbundling of services, duplicate billing, billing for medically unnecessary services, waiving of deductibles or co-payments to entice businesses, and insufficient documentation. Believing that organizations are ultimately in the best position of self-police, the Office of Inspector General developed the model compliance plans for labs in 1997 and for hospitals in 1998. Followed by a dozen other guidance documents for pretty much every type of healthcare provider and service provider, like DMEs and pharmacies. They cover the key risk areas that are perceived to lead to potential fraud and abuse. And such key areas, we mentioned some of these already, may include the upcoding, inaccurate or incorrect coding, bundling, unbundling of services, duplicate billing, billing for medically unnecessary services, waiving of deductibles and co-payments to entice some businesses, insufficient documentation. There's also 16 essential elements that should be noted. And these are self-reporting, culture that encourages reporting, compliance officer, oversight, written procedures, including an employee code of ethics, training, hotline, exercise due diligence with sanctions individuals, monitoring services or systems, established standards and procedures, having things in writing or all of these things that we're talking about in writing, having effective plans, using discretionary authority, independent evaluations, disciplinary measures, and having an audit plan. And so this is another poll. And it says, which of the following are not essential elements of a compliance program? And just to give you a hint, there may be two answers. Okay, so we'll go ahead and end the poll. And most of you answered both number 3 and number 5, and those are the correct answers. Automatic dismissal of any employee excluded from participation, and designation of a compliance officer employed within the billing department. So those two are not essential elements of a compliance program. Code of conduct. The code of conduct is believed to be the backbone of the organization's compliance program. The code of conduct, if implemented effectively and enhanced as needed, can reduce weaknesses by helping employees and agents understand their roles and responsibilities while fostering an environment where concerns and questions are raised without fear of retaliation or retribution. It is a living, breathing embodiment of the program. In the most effective programs, the CCO reports directly to the board of directors or trustees so they can maintain independence. Office of the Inspector General. The Office of the Inspector General was created to protect the integrity of HHS. And so some of these things were to identify and hold accountable those who do not meet program requirements, to publish an annual statement of work, but is now updated as needed and on a monthly basis. Some examples of work plan include initiatives related to prescription opioid drug abuse, Medicare payments made outside hospice, and denials and appeals in Medicare Part D. Some well-known names that were issued corporate integrity agreements includes Tenet, National Health Laboratories, and University of Penn. HIPAA. The goals of HIPAA are the protection of patient information, restrictions of access to PHI or protected health information, and the BAAs, having BAAs in place. Transaction sets. The final rule on transactions standardized the electronic format so that data, remittance advice, and claims information could be transmitted using one type of electronic format. We usually state that there's no standardization in the NSI transaction set, but the rule was intended to do that. The final rule adopted standards for 8 electronic transactions and code sets that are to be used throughout the healthcare industry. Standard Unique Employer Identifier. On May 31st, 2002, HHS released its final rule, Health Insurance Reform, Standard Unique Employer Identifier. The use of a unique employer identifier is required under HIPAA. The rule adopts the employer identification number assigned by the IRS to be used in standard transactions to identify the employer of an individual described in a transaction, such as the transmission of enrollment or disenrollment information to a health plan. Any business required to furnish a taxpayer identification number, meaning that wages are to be paid to one or more employees, must use an employer ID number or EIN as its taxpayer identifier number. The compliance date for the implementation for most covered entities was July 30th, 2004, or August 1st, 2005 for small health plans. The National Provider Identifier, or NPI, is a HIPAA administrative simplification standard. The NPI is a unique identification number for covered healthcare providers. Covered healthcare providers and all health plans and healthcare clearinghouses will use the NPIs in the administrative and financial transactions adopted under HIPAA. It is a 10-position intelligent-free numeric identifier, so 10-digit number. This means that the numbers do not carry other information about healthcare providers, such as the state in which they live or their medical specialty. Beginning May 23 of 2007, the NPI must be used in lieu of legacy provider identifiers in the HIPAA standards transactions. Privacy of health information. So in the privacy of health information provides training to all staff within an organization on its policies and procedures governing the HIPAA compliance. It also defines protected health information and access thereto by individuals, payers, and business associates. It ensures that training is based on job responsibilities of staff who handles protected health information. The only exception to training staff is if an organization is a group health plan that provides only benefits and does not create or receive protected health information other than in the form of enrollment or disenrollment information. They are exempt from having to provide training to the staff. It also ensures that a privacy officer is hired or designated, and it ensures that a contact person is hired or designated to handle questions or concerns regarding the protection of personal health information. Security of health information. The administrative simplification provisions of HIPAA Title II require the Department of Health and Human Services, HHS, to establish national standards for the security of electronic healthcare information. The final rule adopting HIPAA standards for security was published in the Federal Register on February 20th, 2003. This final rule specifies a series of administrative, technical, and physical security procedures for covered entities to ensure the confidentiality of electronic protected health information. The standards are delineated into either required or addressable implementations specifications. And coming up at the key points of this section, each healthcare organization should have a compliance program or must have a compliance program. Within the revenue cycle, staff needs to understand the importance of compliance with federal and state program requirements. Medicare programs, issues related to the three-way window, one-day window, Medicare secondary payer, and advanced beneficiary notice, as well as CCI rules are key to compliant claim processing. HIPAA requirements for privacy and security, as well as the opportunities presented through the electronic transaction sets, also impact revenue cycle operations. And we're up at our last polling question. Identify which option is not a work plan task mentioned in this course. And this is kind of tricky, and I know a lot of information was covered. We'll go ahead and end the polls and share the results. And the answer is actually reconciliation of outlier payments to enable Medicare contractors to perform a final settlement of hospitals' associated cost reports. So that option is not a work plan task mentioned in the course. And we're at the end of our session, so I'll stop sharing the screen and open it up. Does anyone have any questions or anything that they'd like to ask at this point? Remember, the session is being recorded and will be available on the YouTube channel for Florida HFMA. I don't see any questions on the chat. So with that, Sabs asked, can we get it emailed to us? Are you talking about this PowerPoint? Or what are you talking about? Or the recording? So the PowerPoint. So as I mentioned, the materials should be uploaded to the Florida HFMA website. We will definitely check with our head of the committee to see when that will be done. You can also look out for the recording. If it's not this one, you can go to past recordings for unit 1.1 to 1.4. The material should be pretty much the same. Okay, so with that, we'd like to thank everyone for your time, and we hope to see you next week. Have a nice day and a nice rest of your week.